I'm going to start off the presentation today by setting the scene and some of the context, and then Kirsty is going to do the second part of the presentation. So it's very good to be here today and have an opportunity to present at the this suicide conference on International Suicide Day. I guess one of the things that is clear, and this is what Rory O'Connor and his co-authors in the Handbook of Suicide Prevention wrote in their final chapter, in their concluding chapter. One thing is clear: suicide is a complex phenomenon. And from all the things we've heard at the presentation today, we can certainly confirm that. But the other thing also is not just a phenomenon in the sense of it is actually a tragic and human issue, one that is at last achieving some recognition internationally as an important public health concern. Our presence today at this conference, I guess, is indicative of the concern that we all share and the desire to make a difference in terms of suicide prevention. The challenge that we have is how do we translate the knowledge about best practice in suicide prevention? How do we apply that to our lives and to our work? We know some things that other people have talked about, that there are certainly areas that we know, but there is also big gaps in our knowledge. And I guess it's easy to get disheartened about how do we make a difference. And so today I'm going to talk a bit about in terms of the context of what we do know, in terms of understanding the pathway that leads to suicide, talk about some of the key challenges that have been identified in terms of preventing suicide, identifying challenges in terms of how do we identify those that are most at risk, and what is our ability to actually accurately predict that risk, and then what do we know in terms of evidence for the best practice elements in suicide prevention. So then Kirsty will focus on what we can do in the light of these challenges and guided by the knowledge that we have in terms of best practice. When we're talking about suicidal behaviour, it's important that we have a kind of framework that helps make sense of what ends up with an individual developing suicidal behaviour. And there's been a lot of research which has gone into identifying what is the factors what are the risk factors or the factors that come together that create this pathway that lead to suicidal behaviour. And essentially, suicide is not a random event, but essentially is the result of a cumulative effect of vulnerabilities, which are mediated through the development of mental health issues. This framework on the lower level identifies a range of risk factors which come from all the different areas of individual exposure to trauma, family factors, life events, social supports, social economic factors, cultural factors, and macro socioeconomic factors. Those domains can be both risk factors and protective factors. The domain of mental health, particularly mood disorder, we know is the disorder that most associated with the highest risk in terms of suicide. There are also a number of factors, contextual factors, that can also influence that pathway, and over the conference there's been a focus on the role of media, but also particular institutional settings like prisons, cultural factors, communities where there's suicide happening, the whole contagion thing. Those contextual factors also feed into this pathway. The positive thing about having this knowledge is that it gives us some idea of some possibilities for intervention in terms of reducing the vulnerability for a person to go down this pathway. Having said that, we are faced with significant challenges in terms of preventing suicide. And Eric Kane has identified 5 major challenges in suicide prevention. The first of the challenges is the inability to discriminate the relatively few true cases from the large number of what he termed false positives. The issue is that suicide is a relatively rare event, And the clinical and risk factors, which I've just put up there, are actually relatively common compared to the number of people who die by suicide. And so just knowing the risk factors gives us very little predictive validity when applying it to individuals. On the flip side, challenge number 2 is the large number of false negatives, cases that escape preventive detection. There are many individuals that have highly lethal intent that aren't identified. In findings from psychological autopsies, when they look at factors which are occurring prior to the person's death, there seem to be quite significant factors that have contributed to that death. However, in life, before this person died, these features did not raise alarm bells or did not foretell the death of this person. Challenge number 3. The inability of clinical and social services to reach many individuals who have suicidal intent. The reality is that the majority of people in the midst of a life-ending crisis actually do not come to the attention of services. Challenge number 4. A paucity of knowledge about fundamental biological, psychological, social and cultural factors that contribute to suicide risk among diverse populations and groups. Risk factors actually vary by age, race, gender, sexual orientation, geography, social, cultural and economic status, and some of that's been reflected in some of the presentations at the conference. We also have limited understanding of the protective factors that may help diminish the impact of the risk factors. Finally, our challenge, the 5th challenge, is the lack of coordinated strategies for suicide prevention. So ultimately, there is a need for services that deal with the fundamental factors that create the vulnerability to develop suicidal behaviour and to instill a culture that reduces stigma and encourages both the offering and receiving of help. In Eric Kane's words, we must reduce the prevalence of adversities that drive human vulnerabilities towards distress and disease, and at the same time increase people's willingness to grab a helping hand. Coming to the issue of how do we identify those that are going to be the ones who die by suicide? If you look at this diagram here, essentially from a relatively large group of people who experience suicidal thoughts, how do we know which of that group is going to progress through making a suicide attempt, a serious suicide attempt, and or die by suicide? One of the speakers today mentioned that, for every around 30 to 40 medically serious suicide attempts for every death. So our job is very difficult in the sense of determining which individuals are going to be the ones that are going to be the ones that are most at risk. The reality is we don't know enough about that. We have a low predictive ability in that area. This is data from the Mental Health Survey from 2006, a paper that's written by Annette and others, looking at the prevalence of suicidal behaviour in New Zealand. And if we just look at the lifetime prevalence, approximately 15.7% have lifetime suicidal ideation. And of those, 4.5% make an attempt. So again, it's just this point of how do we know which of the ones from the first group are going to be the ones in the second group. Other studies in terms of that are looked at lifetime prevalence, the percentages have ranged from anywhere between 13 to 29%, and in terms of suicide attempts, anywhere between 1 and 10%. If you look at 12-month prevalence, i.e. in what's occurred in the previous 12 months, the suicidal ideation across all ages was 3.2% have suicidal ideation, and of those 0.4% make a suicide attempt. In the youth group on the far right, actually have higher proportion of suicidal ideation in that group, and of that group, 1.3%, so 1/6 of that group go ahead to make a suicide attempt. So in terms of sort of identifying who are the ones who are most at risk is very challenging. What is the other information that we can draw on that gives us guidance in terms of what we do, how do we proceed in terms of addressing suicide? A recent review by Van der Veldt-Cornell has identified 6 levels essentially where there is evidence for effectiveness of suicide prevention initiatives. And I just want to kind of go through and give some examples from each of these areas. The first level is around focusing on primary health and particularly general practice to improve knowledge and ability in the recognition and treatment of mental disorders, especially mood disorders, and detecting and managing suicide risk within that context. So that's things like the use of screening tools in those areas for detecting depression and suicide. It's about providing information and training and treating depression and having national guidelines to assist with that. Information about different forms of treatment and their relationship to suicide risk, and knowledge of populations who are more vulnerable in terms of suicide risk. The second level, where there is evidence for effectiveness, public awareness campaigns and cooperation with local media to improve public attitudes on depression and facilitate help keeping. And so there's a whole range of things in there that relate to information about what help's available, warning signs, risk factors, special information around for vulnerable groups, the websites about depression, suicide treatment options, etc. The third area is the whole area of gatekeeping, and I've never particularly liked the term gatekeeping. I've always felt there was some connotations about it, but someone referred to it today as shutting the gate, and I actually quite like that. It's essentially someone shutting the gate to stop that person going further down that pathway to suicidal behaviour. So whoever made that point, it's changed the perspective of the term gatekeepers for me. So training for gatekeepers and community facilitators on the detection and depression of depression and suicide risk. So the training and understanding more about depression and suicide, the practical elements. How do you talk about suicide? What questions do you ask? Who should ask those? What do you do if someone says, I do have these suicidal thoughts? How to, identifying, helping gatekeepers and community facilitators identify who might be vulnerable. I think that the Mates in Construction presentation was a fantastic example of connectors. Was a great example of people who essentially have that information and knowledge and basically are able to identify and facilitate a person getting help for whatever's happening for them and reducing their isolation. Services and self-help activities for high-risk groups to facilitate access to professional help. And level 5, restriction of access to potential lethal means of suicide. Again, there was some examples in the presentation of how some of those changes at that level can make a difference. Or it might have been in our media one yesterday talking about somewhere in Asia, but also in Auckland we have a local example with Grafton Bridge, with the barriers going back up on Grafton Bridge and how the suicides dramatically dropped from Grafton Bridge, and they weren't replaced by another bridge becoming the place where people jumped. But also restricting access to means is also an area where it can be applied right down to an individual in terms of managing risk of an individual as well. And the 6th level is improvement to access to care. So improvement of acute, continuation and maintenance treatment, including at times hospitalisation, aftercare and easy entry to care, for people who make suicide attempts. There's been work done around people presenting in emergency departments and follow-up, what level of follow-ups for people from emergency departments. Telephone support and other forms of contact and emotional support for persons known to have engaged in suicidal behaviours or suicidal ideation. Again, it reminds me of a comment Roger Mulder made about about people being in a treatment study. Maybe one of the factors that actually makes a difference is the fact that someone's actually interested in their life over the next 5 years, and something as small and low level as that actually may be quite significant. So the next part of this presentation I'm going to hand over to Kirsty to focus on actually what we can do in light of some of these challenges, guided by the knowledge that we have from the best practice elements, but also in combination with the experiential evidence and the understanding of New Zealand, our New Zealand context, and the diversity of the communities actually within our country as well.
Thanks, Maree. Kia ora koutou katoa. He nui to begin with, just to those who have spoken already today. I'm really mindful as people were talking that I was thinking, I'm talking about that too, or that's what I'm saying. There's a lot of, I think, similarity coming through in the things that people are doing and the work that's been done, which is really exciting. In the media workshop last night, I mentioned, and today as well, that we need to be very humble about what we do, and particularly about what we don't know in this area. And I think in light of what Maree put up there, it can sometimes feel a little bit overwhelming in the context of there are risk factors that we're aware of, but they don't provide a set pathway. There are individual studies that indicate interventions that might work, but they only work for some. There are larger multi-level strategies that have kind of okay population outcomes, but how do you translate that to the individual in front of you? And I guess in that context, the question can be raised, what do I do with this person within the role I'm in that's sitting in front of me right now? As Annette said, I work for the Toward Wellbeing Program, which is a child, youth and family initiative. And what I'm talking about today is sort of loosely based on the framework that we used for that, which is around educating people about vulnerability and recognising that in the people that they're working with. It's about taking that and asking the questions that need to be asked, and then responding constructively to what comes out of that to enhance protective factors and address the vulnerabilities that come up. And so I guess my challenge to you today as you listen to some of this is to think about, I'm aware that all of you come from a wide variety of roles, that how does this translate to the role that I'm in with people who might be at risk of suicide? How might I take some of this and apply it in the work that I do or the people that I come across? One of the things I was just saying to some colleagues before, I kind of feel like this is the speed dating version of identifying and managing risk in terms of the time frame I've got. So forgive me if I whiz through things or oversimplify matters, because as we're well aware from the rest of the things today, this is not a simple matter. But I hope that I've kind of pulled on some core strategies that might help people in their workplace. And they actually, I should say, they are, I'll tell you them right now, you don't even have to wait, they are be aware, ask and connect. So for those of you that like acronyms, I was also having a little giggle with some people before, that's BACK, so I've got your back, so if you like that one. So the first strategy is be aware, so being aware of vulnerability, being aware whether that person in the room with you or alongside you may be more vulnerable to contemplating suicide as an option when things are difficult. As you saw from the pathway that Maree put up there are multiple risk factors for people, and they differ by gender and by age and by cultural group and a whole lot of other ways. But they really do come down to the same question when you're working with someone on an individual basis. What are the things in that person's history or in that person's current situation that might make them more vulnerable? And we've seen people talk about what some of those might be today: previous suicide attempts, exposure to suicide and family and friends, mental health diagnoses, significant life changes, loss and loneliness, physical impairment in the elderly, that sort of thing, as well as personality characteristics, impulsivity, A&D, conflict, loss of jobs in terms of current stressors and that sort of thing. Now, these aren't necessarily causative, but they're known to have a relationship with suicide, and so weight towards someone being more vulnerable. Alongside that, and it has been mentioned again today, and very importantly, there's the absence or presence of protective factors, the things that will help protect someone against suicide: supports, good problem solving, good help seeking, spirituality. So these are the sorts of things that can be looked out for, and they do differ for every person. Now I've got down at the bottom there about what kind of level you may be engaging or working with someone on, and I think this concept of being aware is important regardless of which level. Second one there is ask, and I put ask/listen because the two should, oops, I'll just leave that, might rather than fiddle, should go hand in hand. And obviously asking will vary considerably dependent on the role or relationship that you have with the person. The way in which you ask and what you ask will differ, but we all do have a role. Maree's mentioned the gatekeeper training at one level, which is around those educating around how to ask questions and that sort of thing, and there's some examples of good gatekeeper training that's out there at the moment. At the other end, there's the mental health assessment that have tended to be relied on to provide information around, I guess, degree of risk, ideation, the degree of planning, intent to die, reasons for dying and living, protective factors, that sort of thing. And whilst they can be incredibly useful for this and can give some really good information about degree of risk, particularly at a given time, and also possibly more importantly about the presence of risk factors such as a mental health diagnosis, we have to acknowledge that they are limited. First of all, you have to get a mental health assessment, which we all know can be a bit of a challenge at times. Then you've got to get the person to the mental health assessment. They've got to meaningfully engage with the assessor and be honest about the information that they give. And realistically, they need to keep engaging if you want to have good assessment over time rather than just capture one moment in that person's time. So again, recognising those limitations, it means asking becomes everybody's role, not just something that we put out there with mental health will assess their risk. The next thing there is asking in a way that is meaningful and engaging within a cultural context and understanding, and I think Lynn spoke to that today as well, how important that is, and within a context of relationship, of respect and trust. And I'm not necessarily talking about an ongoing or long-term relationship there, but more perhaps about the way in which questions are framed and asked and the meaning it has for the person in terms of why they think you're asking them. When people are already hesitant to seek help, when they're worried about what someone might think of what they say, when they're worried about what might happen if they tell you what's going on for them, a relationship of trust or respect can go a long way into easing that in terms of the information. Ask about the whole picture. So this is not just, are you thinking about suicide? No, whew, okay, that's more what is going on for this person. What's making them vulnerable? What are the risk factors? How seriously are they thinking about suicide? So ask and ask some more. Historically, what's been happening for them? Now what's going on for them? And I think an interesting question to ask about that is, who's in the best position to get that whole picture? And sometimes it's not the person who's going to see them for 1 hour, who's never met them before and has a really challenging, a huge amount of information to get through. It may be the person who's worked alongside them in a community in a different role, who can help with the sharing of that information and passing it on. But I think it becomes more than just one person's responsibility. And I've got asked without stigma and prejudice there, and I'm cautious about using the word stigma now, given some of the discussions that have happened. But what I guess I'm talking to there is if you're embarrassed to ask, then there's this communication of this message that this is something not talked about. It's not okay to have these thoughts, something's wrong with having them, getting caught up in the what ifs. So without having assumptions around why someone might be feeling a certain way, what it is to talk about those, there's a little, I don't know, can you actually see that? Can you read the writing in that? Or am I going to have to read them out? This is from the UK Mental Health, and it's from the Like Minds, Like Mind Facebook page. They have these lovely Friday night sort of slots where they post something up, and it starts off with saying at the top, some conversations are scary. And there's a little guy saying, I actually can't read it either. It's too small in my notes. Something along the lines of, would you please stop invading our country? And the big robot saying, oh, we'd rather not. And then at the bottom one it says, some aren't. And this guy's saying, oh, hi Andy, how are things going for you? And the guy's saying, yeah, good days and bad days, but they're getting better, thanks. And at the bottom, and I appreciate having been sitting at the back, you can't see the bottom down there, but it says, don't be afraid to talk about mental health. And I know obviously we're talking about broader mental health in terms of suicide today, but I think it's that same thing. We need to have these conversations, and we need to start feeling comfortable about having these conversations. And then we need to keep having them. We need to keep asking. It's not a one-off. the title of our topic had the word dynamic in it, and I think that's just an incredibly vital message that risk changes. It changes over time, and we sometimes talk with social workers quite a bit about chronic versus acute. That particularly mental health assessments sometimes are done in an acute framework. What's the risk of this person doing something right now when they leave the office, versus chronic, which means that the vulnerabilities and the absence potentially of protective factors mean that this person, should something go wrong or something happen, relationship breakup, that sort of thing, is more at risk of choosing suicide as an option. Triggers, stressors, we know that they come and go. The things that make us vulnerable come and go, and similarly resilience and protective factors change. So in the same way, we need to keep asking and having these conversations. And I've got a little picture or image up there of a door, and with our caregiver training we sometimes talk with caregivers about, by asking the initial question of a young person, in this particular example, you're opening a door to them. They may say, no, I'm feeling fine, no, I never think about that sort of thing. But what you've done is you've said it's actually okay for us to talk about this. And even saying, you know, if any time you do feel like that, if things, you know, it's okay to come and talk to me about it. You're opening the door, you're sort of, I think of perhaps stigma, shutting all those other doors. You're opening those doors and saying it's actually okay for us to, and it's actually more than okay, it's really important for you to feel comfortable to come and talk to me about this. So there we've got be aware, ask, and then I've stolen from Mental Health Foundation here with Connect, with their upcoming mental health awareness theme. And I thought it was great, the connectors with the mates in construction as well, because the final thing I'm talking about is connecting, and I really have stretched the meaning of connection, so please forgive me for that. But connect initially to the person, to things that might decrease their vulnerability and to things that will increase their protective factors. And again, the role you may play in that will differ depending on what your relationship and role is with that person, whether you're friend, family member, mentor, school guidance counsellor, therapist, that sort of thing. You may be supporting them to get to the people who can connect them to these sorts of things. You may be accompanying them, you may be providing the service. But I've listed there some of the things that there is an evidence base around. Annette, this time last year, did a webinar around the sort of evidence base for some of the protective factors, and some of those come from there. So there's some really good resources out there about the sorts of things that work. And then connect it all together. You see, this is where I start to stretch the meaning of connect, in a plan. And I think plans are interesting things. I think when they're done well, they can really provide a sense of hope and of way forward, clarity for those involved. They need to be tailored to fit the person, and I'll jump right down to the bottom here, because I think what's vital in this is whose plan is it. So if you think of the meaning of a piece of paper that a clinician scribbles on the hospital paper that with some of these things on and hands it over to the person and says sort of here's the plan, doesn't hold a lot of meaning for that individual, versus a plan that is written by that person with their whānau, with their support people, with others contributing to it. There's a sense of ownership. There's plans that are addressed, mentioned here, around the immediate or the acute situation. What would we do if there was a time of crisis when suicidal ideation really went up? What are warning signs for someone, coping strategies, people they can go to? And we've got an example here of, sorry, that's very small again, but that's some of the example of a plan that we'd use with child, youth and family, with the social workers to go through, do their own personalised version with a young person that has signs I'm feeling okay, things that help me feel happy and well, things that upset me, and, you know, if these things happen, where do I go, what do I do about that? So we really stress sort of personalising that to make it meaningful. Alongside that, there's an ongoing plan, a plan that addresses vulnerabilities, major typo there, that increases protective factors, not risk factors, apologies for that, and where you can see how people are going to work together to support this person, to support this whānau in terms of what's going on for them. And I've put there who, what, by, when, which is something that we use with CYF, which is very much around, you know, who's taking responsibility for this, what is it that's going to happen, and by when. So there's a real kind of clarity around the different kind of supports that are in place for a family or for an individual. And the things I've already mentioned there, really get feedback, include others, ask if there's anything else, problem solve obstacles, and the importance of it being an ownership for someone. And then once again, and you probably can't see that down the back, it doesn't really work with the bottom line of the video here, but is review it. Similarly, risk being dynamic, plans need to be dynamic. A plan written at one stage may not work as things change, and they need to be adapted to fit what's going on for someone. And lastly, to stretch it as far as it will probably go, connect with each other. And I think that's been a real theme of today. We need to connect with supports, with other agencies. We need to work together to maximise supports and to close gaps, connect with the literature, what's out there. We've had some great resources in New Zealand, and a lot of those have been mentioned today. Mental Health Foundation is a wonderful e-bulletin that has kind of little snippets of what's working and what's been done in different places to keep in touch with what's happening in New Zealand and internationally. And there's a number of other things like that. I'm aware I'm at the end of my time. So in summary, suicide is complex with multiple pathways. There are significant challenges with identifying particular individuals at risk. The body of knowledge is growing, but it's still incomplete. But at an individual level, you can be aware for vulnerabilities and protective factors. You can ask and listen, and that little thing there is keep asking and keep listening, and you can connect people up with things that might work for them. And then finally, I've got the good old JK picture of hope there, that we will find a path forward for the individual, for those at risk groups, and for those working to prevent and lessen suicide.